All right. Start you out with the fun one. Some arrows. Okay, right. So he's on the edge. Yikes. Remember, it's 55 is the low end of your GFR, 55 to 60. 15 is like end stage renal failure and close to it, maybe under 10. You're very close to end stage renal failure at this point. Okay. So this is a very important question. Now, in very simple terms, what are they asking you? What should you expect to find in a patient in chronic renal failure? Okay, this is a great question. You test so many different caveats to it. So does anybody want to try this one and see if they can walk through it? If not, I can do it. I just wanted to see like which ones y'all would pick first so we can rule things out since y'all are getting new to this. But
I would want probably the wherever there's increased calcium, because if there's kidney disease, their calcium should probably be lower.
their
So
calcium should be lower, right? Because they're peeing it out,
and
right?
then cause their PTH to go up.
Okay, so hold on one second. So then if we're going with, I agree, serum calcium will go down because they're peeing it out. So if that's the one you want to use, then we have to get rid of B and E. Okay, so yes, now we go, you want to go parathyroid? Perfect. That would make the parathyroid go out. That gets rid of C. Okay, now what?
And I think phosphate should go up with the parathyroid.
Exactly, because and then yeah, so look, we got our right answer just by finding three. And you're correct, because remember the job, and that's in the distal convoluted tubule. You're talking about this whole thing right here. Distal convoluted tubule. We know that PTH works. In renal failure, chronic renal failure, those receptors don't work well. The parathyroid hormone does not bind well. The whole channel system of bringing back calcium and peeing out phosphorus doesn't work. So if it's not working, we have to look at what's the consequence. You're losing calcium. You're holding on to phosphorus. You're supposed to get rid of it. Okay, perfect. We didn't even have to go any further. But if we were to say we know 25 hydroxyvitamin D is in the liver, not affected. Very importantly, I want you to know the 125, remember that one is the one that it gets converted in the kidney. Is the active version, calcitriol. Remember that some people use triol with the tri as in three, as it has 125, 123. So calcitriol is the active form of vitamin D. You need one alpha hydroxylase. One alpha hydroxylase in the kidney to form this. So what they're saying is the person doesn't have liver failure. You're fine getting the vitamin D to the liver. But when it gets to this enzyme, not working very well in the kidney, so you're not going to form the active form. So there, you get that as well. Okay? So that's the name of the game with these crazy ups and down arrows. But as you can see, you can, if you just do the ones you know first, some of the other stuff falls into place and then it just gets easier. Okay? So don't freak out when you don't know one column. Just work with what you got. All right. I like that question. Okay. And this is basically what we were saying. So think of these separately. Okay. This is due to the enzyme here. This is due to those calcium phosphate that those transporters due to PTH, right? PTH not working, right? And this is that alpha hydroxylase. And you can see this. Um, yeah. And if you don't have vitamin D, remember vitamin D, we go a little bit back to GI. Remember, vitamin D has a synergistic effect That is the whole point. That is how vitamin D fits into this little love triangle here. Vitamin D actually brings in calcium. By having vitamin D, you absorb more calcium in the gut. So if you don't have the active form, because kidney failure and that enzyme's not working, you're not going to absorb calcium. All right. And then we have high phosphorus. So bad situation. Okay. And then, of course, our consequences increase PTH because you're trying to correct for these issues here. You're trying to correct for this and correct for this. Let me tell you this. This is a very important thing about PTH. I don't think people realize the idea of pulling calcium off the bone is a very bad thing. Okay. So when you think about PTH, it's a last resort. You don't want to make your bones brittle. Okay. So PTH can pull calcium off the bone if it has to. But ideally, it's going to work within these confines of the kidney to just titrate it. Okay. It's a last resort issue when you start pulling stuff off the bone. Like you could really think about it. Yeah, of course, it's a bad thing. It's a last resort consequence to bringing the blood calcium up. Okay. So that's just a good thing to keep in mind. All right. First baby. All right. Okay. So one of the things is you can't really go acute or chronic. She's stable. Baby is stable. Unilateral. Unilateral matters when it comes to these urinary problems versus bilateral. When you have things like the posterior urethral valves, that can present as bilateral hydronephrosis. This is unilateral. Note that they told you this. This is a pertinent negative. Why did they tell you this? Because if I drew the kidney out here and I drew the ureter, if I had a stone stuck down here, maybe even like right here, or yeah, like right there, let's use for example, and they would have backflow into this ureter, you would have ureter dilation, ureteral dilation, right? If it was down here. So they're basically telling you it can't be there. So where's the most common site of this hydronephrosis that doesn't involve any dilation of the ureter? Well, how about right there? That's that same place we get those stones in adults. Uretopelvic junction, right there. So do you get ureteral dilation there? No, you still get hydronephrosis. All of the fluid is backed up in the kidney, but none of it is in the ureter. The stone's not down there. So you could see how this pertinent negative comes in. You want these things to flash out in your head. If you do enough of these, they start popping out in your head. Okay. Okay, so you can see here, if we put the stone right here, we're not going to get any ureteral dilation. If we put the stone right here, or at that point where it goes over the pelvic brim, you would get some sort of backflow and you get ureter dilation. But if you put it at the pelvis, you can see there. And as you can see, temporary narrowing of the uretopelvic junction. Okay. And since we're talking about it, keep in mind when you talk about this is a narrowing, but this is very similar. And the more often tested version is talking about stones, right? And when we talk about stones, we talk about the uretopelvic junction. We talk about when it goes over the pelvic brim, over those muscles, and the uretovesicular junction, right? Those are our three major points of concern. Now, when you look at a picture, if you were to determine where it is, you are going to look for the ureteral dilation, right? At what point is the ureter dilated? Everything is backflowing from that point. So if the entire ureter, it looks tortuous and distended compared to the other side, then it's probably at the point where it's entering the bladder. If it's only halfway up, then it's right here at that brim. If you don't see any dilation and it looks the same as the other side, then it may be stuck up here, okay? So use those to your advantage. All right, 65. Never like to see that. Mm, that's a long time. Okay, she's a smoker, big time smoker, lung cancer. We know the two, um, the two cancers that smokers get are small cell lung cancer and squamous cell lung cancer. Both of them are on the hilum, right? Right around the hilum. If you were to get one way up here, at least for you guys for now, that's considered peripheral adenocarcinoma. Those are the ones non-smokers get. Okay, let's go back. She's a big time smoker. We have two options, small or squamous. What are we going with?
Squamous because of the hypercalcemia.
Because of the hypercalcemia. Okay. So, and what is causing the hypercalcemia?
The parathyroid related protein.
Very good. Right. Remember, it's not actually PTH. It just so happens to look like it, right? I don't know if that's random, just random. I don't know how these paraneoplastic syndromes work, but the idea that it made something that looked very similar is kind of strange. I don't know if the science has an actual answer for that. But yes, it's PTHRP, right? The P related protein, and that's what's formed there. So your actual, keep in mind, that would imply, since the calcium's high, that your actual PTH should be low, right? Because this is doing all the work, right? It's bringing these levels so high, you would get a feedback to your normal PTH, okay? So your normal PTH will be low. What are so there's three things that happen with small cell. We have, help me out, we got ADH, was it ACTH, and then Lambert-Eaton, right? Y'all can please correct me if I'm wrong. I'm pretty sure that's correct. So remember with small cell, and this person has squamous cell, that's what we've decided because of this. But with small cell, you can have inappropriate ADH, so the person can be holding on to fluid, ACTH, so they can have cushingoid symptoms, or Lambert-Eaton. Remember, Lambert-Eaton syndrome is kind of like the opposite of myasthenia gravis. Okay? I want you to remember two things about Lambert-Eaton syndrome. One thing is it's related to small cell lung cancer. The other thing is it's kind of opposite of myasthenia gravis. When you think of myasthenia gravis, when you're testing the patient and you have them do curls, as they do curls, their muscles will get weaker. Okay. And that's because of the autoantibodies and whatnot. Now, in Lambert-Eaton syndrome, it's the opposite. As the patient does curls, they will get stronger, and that's because it's a slow buildup of calcium. Okay, so just keep in mind, I'm just trying to point out different things that I remember. I like things that have hard lines. Okay, when I can say we'll never forget these because they go together. I try to keep these together in my mind. Okay, I try to compartmentalize things as much as I can. Okay, keep things as objective as possible. All right. And this is just looking at all types of hypercalcemia um, in different types. So you can read over this. Okay, she was okay. Always important right here when we talk about someone coming in like this, drowsy, a kid, do they take something? What we don't know, 16. I always go to this. All right. You need to take a minute and sit down and make sure you understand the difference between uppers and downers, right? What does cocaine and amphetamine look like when they're intoxicated and when they're in withdrawal? Their eyes, their symptoms, their whatever. The same thing goes with downers, things like heroin, opioids, stuff like that. What do their eyes look like? Pinpoint when they're intoxicated, and blown when they're in withdrawal. Those are easy points. Okay, so be careful with that. As soon as they tell me they have normal sized pupils, I start eliminating things. I'm starting to think about, did this kid get drunk? I don't know. Did the benzos don't really change your pupils? Stuff like that. So that's what I'm looking at there. I always key in on that if that's there. Tenderness over the epigastric area. Okay, so not too much information. I mean, let's look. We could take a peek and look and see. I mean, that sounds kind of weird. There's no symptoms of that he's had that, but we don't really know. Let's take a look at the labs. Okay, bicarbs low, right? Remember, 24 is our number. Lactic acid, venous blood. Okay, right. 7.5. So here's the thing. It looks like he's in a state because the bicarb is low. Remember, that would tell us, I wish they would give us the actual pH, but if the bicarb is low, that would mean he's in a state of metabolic acidosis. Now, I'm still kind of thinking, I'm like, okay, let's take a look. Ethanol, no, not really. Aspirin, okay, I do know something about aspirin. I know two things about aspirin. It has a, it is the one example that they like to use with acid-base disorders. They like to use it because it has very special properties. It has both primary issues. It causes a respiratory alkalosis due to hyperventilation, and it causes a metabolic acidosis because it is salicylic acid. Okay. They like this example because the acid based stuff's pretty easy. You have diarrhea, you lose a lot of bicarb, you throw up, you lose a lot of acid. You take opioids, you don't breathe a lot. You have anxiety attack, you breathe too much. It's pretty straightforward. Aspirin is that one example where they can get you because it has two separate things. Okay. So I want to investigate this because I've got one of them. I've got metabolic acidosis. So where do I check? Oh, perfect. I would expect hyperventilation because this would imply that he's blowing off carbon dioxide. So he is in a state of respiratory alkalosis. Game over. We're done. That's it. Okay? Make sure you understand aspirin. Two separate primary problems. It's a great example. Okay? Good teaching points there. Put a star there just so you can see that aspirin. Yes, don't forget the tinnitus. Aspirin will do the tinnitus thing. Okay, they may give you that on step one, probably not in step two. You can see the increased lactic acid as well. They'll give you that on step one, and you would expect an elevated anion gap in this situation. Because it's not a bicarb or a chloride problem. It's a new acid that was introduced. I know this is what I was talking about. As you can see, I mean, there's so much here, and they just ask a question. They just ask a lot of questions about it. So it's just like bite the bullet and just learn this stuff, right? And you can see rapidly progressive over here. You have your ANCA, and they're talking about. But yeah, you just kind of have to bite the bullet. Look, this is the IgA nephropathy that I was talking about earlier. Occurs concurrently with respiratory and GI infections. That's different from this, right? Remember, this is 2 to 4 weeks after. Okay, so that's what I like to do. This is the name of the game when you can do things like saying, they'll ask me a question about this and they'll say, what is the time frame? And I'll get it right because I'll know. Okay, so that's what the kind of things they'll ask. Then there's things like Alport. Remember, that's a mutation in type 4 collagen. And you get the triad, the eye problem, the glomerulonephritis, and then the sensory neural deafness, eyes, ears, and kidneys, right? Can't see, can't pee, can't hear a bee. A little different than the other one that they use, the Climatree one. And then your nephrotic syndromes, right? Minimal change, right? So it's not fun. Know this one. Know the picture for diabetic. Know which one. I can't get to it. The chat thing's in the way, but yeah, know the picture for the diabetic. They liked when we moved the chat box. Yeah, they like to talk about the how they look with these big nodules here in the diabetic form. Kimmel-Steele-Wilson nodules. Yeah, they don't expect you to know a lot about pathology, but you know, like the owl eyes, they like you to know that. These Kimmel-Steele-Wilson nodules are pretty diagnostic. They're diagnostic for diabetes, and since diabetes is so common, they like to test it. So I put this on here. Yeah, you just kind of have to bite the bullet and commit this stuff to memory. Hmm. All right. So they told you all this, and then they kind of give it away, right? They say, well, look, it was the ibuprofen. It was. All right. So what are we talking about here? And this is we're gonna do a little review here with this stuff because this is very highly tested. They want you to know this stuff. So if you remember, prostaglandins will are increased. That helps with afferent arteriolar dilation. So if you give someone NSAIDs, you will decrease prostaglandins and you will cause afferent vasoconstriction, right, or impaired dilation. Okay, so we're going to review this. I have a blank little slide so I can draw on it. And we're going to go over this because there's a couple of different things I want you to know. Okay. So we want to dilate our afferent arterial. Here's our glomerulus. And that's our, okay, so this is afferent. So blood's coming in and then blood goes out here, right? Now, 80% of your blood is going to go from afferent to efferent. 80%. 20% is going to be put through the pasta strainer. 20%, do this. 20% is going to be forced through here, right? The path of least resistance is this way. So most of the blood is just going to go straight through. But 20% we're going to put through the pasta strainer to get into the urine. Okay, now there's a couple of different ways that things in our body can affect this. If we have afferent afferent arteriolar dilation, we think prostaglandins. If we dilate the afferent arteriole, if we dilate this, more blood could come in. We didn't dilate the efferent, the outflow pipe. So since more blood can come in, more blood will be filtered. So we get an increase in GFR. Prostaglandins will increase our GFR. Now, what happens if we give NSAIDs? Well, now we've actually constricted our inflow tract. Okay. So now blood trickling in. So now we gave NSAIDs, right? So we basically blocked prostaglandins. And that was what the question was saying. We blocked prostaglandins. So we constricted this area. So we can all appreciate that if there's less blood coming in, we're going to have a decreased GFR. Decreased renal blood flow, decreased GFR. Here we have increased renal blood flow because we dilated the afferent, our prostaglandins. Okay, and increased our GFR. Okay, so the moral of the story is all your family members that pop like 3 or 4, and my mom pops like 3 ibuprofen when it's like, yo, it just because it's over the counter doesn't mean it's not bad for you. Some of this over the counter stuff that people think, well, it says 2, I could probably take 3, and it's like, honestly, you're really screwing yourself up. People don't know. People really don't realize. But yeah, a lot of renal failure in this country and all the diabetics out there shouldn't be taking this stuff, right? You know? Okay, that's my rant. Now, let's look at the other side for a second. It's a different situation. I want to do the other one first. So we're going to leave the afferent the same, but this time we're going to constrict the efferent. Okay? So what does this? What does this is angiotensin 2. Perfect, right? Now, since we're talking about it, let's just slow down for a second and back up. Angiotensin 2, it has a couple of roles, but 2 major roles. Role number 1, it has the word tense in it. It tenses down on vessels, particularly this efferent arteriole. It tenses down, okay? Also, it activates aldosterone, okay, which is good because if the RAS system is activated, that means we have low volume, low blood pressure. So we need to tense down on the vessels and we need to activate aldosterone to bring up our volume. It will also activate ADH to a degree, and it activates thirst. Okay. Now, that's the main point there, but I want to get back to this. So it has the effect of constricting the efferent arteriole. So when our blood comes in, what happened to our path of least resistance? Well, now even more blood can go through the pasta strainer because we made it harder to get out. So what did we do? We increased our overall GFR. Now, keep in mind, did I change the amount of blood coming in? No, that was this different situation when I was dilating and constricting the afferent. I'm not changing the blood coming in. Okay? This stays the same. So inevitably, you get the decreased renal blood flow. Okay? Because when you look at it across this, the blood flow compared to if it was normal, if it was this was normal, you get an overall decrease in renal blood flow. Okay. Because you're pushing more of it through the filter. Okay. Now let's just take a look at the other side. We're not changing the inflow pipe. Okay. And we have our, now what we're going to do is we're going to give an ACE inhibitor. This is the other example they use. And what do ACE inhibitors do? They inhibit the conversion of angiotensin 2, right? So by giving an ACE inhibitor, you don't tense down on the vessels anymore. So your outflow pipe is going to get bigger, right? Let me say that again just to make sure we have it straight. Angiotensin is going to tense down on the efferent arteriole. If you give an ACE inhibitor, you cannot tense down, so you will get dilation here. Now you can see that the path of least resistance, because you dilated the efferent, is going to go this way. So what does that mean for our GFR? Well, our GFR is going to go down. What does that mean for our renal plasma flow? Well, that means our renal plasma flow, because it's going, that's the amount that's going straight through. Our renal plasma flow, our renal blood flow, all go up. Okay? So I just wanted to break that down there because there's an example for the afferent with the prostaglandins and NSAIDs. There's an example for the efferent with the angiotensin 2 and the ACE inhibitors. So you need to know this, and you need to kind of be able to do this in your head and know what goes with what. Okay? I hope that was clear. Okay, and this is kind of just what I was saying. And this is the NSAIDs. This is how prostaglandins work. You give NSAIDs, you block prostaglandin formation. You constrict here. If you constrict here, less blood coming in, GFR goes down, renal blood flow goes down. 3 days. All right, well, 3 days is enough time to get some of your labs to go out of whack, depending on how bad it is. All right, so what do we lose with diarrhea? You lose a lot of stuff, but for mostly they talk about, at least in med school, bicarb, you lose a lot of potassium too. But for you guys, when they talk about diarrhea and acid-base problems, they're talking about bicarb, right? Okay, that's where we have to go with this. So if it's a bicarb issue and we're losing bicarb, then the pH has to go up, right? We're just doing our little thing backwards. So 1 is do the pH, right? We lost bicarb, so increase pH. Now because it's a bicarb issue, it's a metabolic issue, right? It's not respiratory. We would assume that you get respiratory compensation because that just involves you breathing normally. And yeah, so it's a metabolic acidosis because you're losing bicarb. And remember the breathing, it's been 3 days. Her breathing has compensated. It doesn't immediately. So you would expect compensation. So you would expect you want to, since CO2 is an acid and you're in a state of acidosis, you want to decrease your CO2. Okay, so that should be our answer. Our pH should, I'm sorry. Yeah, exactly. Yeah, right. So since we gave bicarb, our pH would actually be acidosis. Yes, like I said, acidosis here, right? So, yeah, and that's how we did it. So we got our low pH, acidosis. We know we have low bicarb because you have diarrhea. So low bicarb, we're pretty much done here. We didn't even have to do it. But if we want to check ourselves, if we're trying to blow off acid, blowing out acid, you want your PCO2 to be low. So yeah, right. So A, right. So let's double check ourselves. We're losing bicarb, low pH, right? Acidosis, low bicarb because we're losing it. And then we're trying to blow off acid. Um, Does it say that correctly? You're in metabolic. You're in a state of metabolic. Yes, you're in a state of metabolic acidosis. So you want to blow off your acid. So it's low. All right, there. Uh, all right. So we're good with those, huh? We know those. This is a great. I should put a star on this slide. Know what does what, right? Remember the big ones. They like diabetic ketoacidosis. For that, they do the diarrhea one. Um, uh, Metabolic alkalosis is usually vomiting, right? Oh, vomiting. Here it is, vomiting. And then respiratory acidosis, opioids is the big example they use there. Respiratory alkalosis, they use anxiety is the big example there. They can also use altitude. Okay. Don't get these wrong. These are easy points. You guys are too smart for that. Okay.